next speaker is Miss Leila Reid, who will be presenting her presentation titled Increasing Hepatitis C Testing in Prisons. Can prisoners do it themselves?
Thank you. Hi, everyone. It's lovely to be here. My name is Leila Reid. I work for the Hepatitis C Trust. We're a national NGO working in all of the healthcare teams in England, and we work in all of the prisons in England as well with lived experience staff using lived experience models. And I'm very pleased to be able to talk about this project that we've been doing for a couple of years now, but we're talking about the kind of the first year's activity, which has been training people within the prison, residents of the prison as we tend to refer to them, some people call them prisoners, to do the testing, to test for hepatitis C on entry. Is it the blue green button? So there's my disclosure of interest. Really what I should add to that is a huge amount of work has gone into all of this. I'm standing here as the research person who wrote it up, and because some of our prison team aren't here, but I didn't do any of the work, and actually all of them deserve all of the credit for all of this stuff, particularly the volunteers within the prison, the healthcare team, the prison governors, all of the brilliant collaborators that we've had developing this project. So I will not look backwards, I will look forwards, even though it's quite hard to see. So this is, the model kind of revolves around opt-out testing. So in the UK, we've had opt-out testing since 2013, so like 10, 11 years. And so in theory, everyone coming into a prison should be tested for hepatitis C. Normally that would happen within the first couple of days. By the kind of the data collection is within the first 2 weeks. So strangely, we don't actually have apparently national data on this. So I've had to kind of scrabble this chart together from different areas, from different papers. But it gives you a bit of a sense of how opt-out testing has increased over the last 10 years. So we've got a really good trajectory, but it was very, very low to start with. And that sits within a elimination program, which has got a big focus on prisons in the UK. And we've had peers in our prisons for about 7 years. We've had mass testing interventions, which then lead into the opt-out testing for about 5 years. So it's part of a very kind of robust system. Everyone gets treated within the prison. No one needs to go to hospital unless there's another reason. And lots of our prisons have CEFID, have point-of-care RNA testing. So at the moment, about 76, I think we're on, % of the country of people going into prison will get tested. But that 76 is an average, and some of the prisons are up on sort of 90, 95, 100, and some of them are much further down. The context of this particular intervention was a prison in Birmingham, which is the second biggest city in England. And they had very, very low rates of uptake for our opt-out testing. So it was around 10% at the time when we started. HMB Birmingham is a category B, what we call a category B, so it's a sort of medium security prison. And it has about 1,000, 1,200 men living there. And it's a local prison, and what that means is a lot of the people there are either awaiting sentencing or they're in the resettlement process, so they're there for quite short amounts of time. So these prisons often have a lot of people coming in and a lot of people going out. So there are a lot of systemic barriers to providing opt-out testing in prisons, and in this particular prison, because there was very high reception testing, so about 10 or 15 people a day, and there was a very limited staff capacity at that time, and lots of other priorities. The prison had had some significant problems over the kind of preceding years. They'd had a new governor brought in 2018 to really turn the prison around. So there had been lots and lots of problems. So people's attention was very stretched and wasn't necessarily focused on things like bloodborne virus testing. And then it's kind of obvious, but just to say that those barriers to testing obviously sit alongside lots of other very well-established barriers to testing, like people's level of trust in healthcare, how much they believe that what's being done is for their own interest. And they're kind of, your first couple of days in the prison, you're not like, oh, I want to have a bloodborne virus test. You're thinking about a whole load of other things going on in your life. So there's lots of other reasons why testing rates are low in some prisons. But this prison had some really awesome assets as well, and I think this was really fundamental to this initial pilot that we started coming on board. So they had a governor who was brought in to turn the prison around. He had a proper mandate for change. He was allowed to do things, and he was not a risk-averse guy, and that made a massive difference. He really, really believed in trying new interventions. But they also had a group of volunteers who were residents of the prison, led by a guy who had been brought by the governor from his old prison with him into this prison, specifically to set up a kind of resident advocacy, I suppose, service. So they're called the Expectations Team. And Expectations are, it's a national system about human rights for prisoners, basically. So they're talking about things like safety, things like equalities, and also things like health and well-being for people. So this team had a really kind of strong presence in the prison. They had their own office, they had a computer, they had a printer. They kind of ran health days. They did lots of cell-to-cell visits for people when, during COVID, people were stuck in their cells for 23, 24 hours a day. They would be going cell-to-cell and doing well-being checks. So they'd done health interventions as well. And their office was just down the hall from the governor, and they had a very strong line to him. So what that meant was we had a really good volunteer group who we started working with initially in our peer model, which tends to be about sort of training people to raise awareness and deal with stigma and train healthcare workers and those sorts of things and prison officers in the prison, and then continue to work with them. So the Expectation Team had regular meetings with healthcare, and this issue of low hep C testing kept coming up. And their view was, well, that we've shown that we can do loads of other stuff, so why can't we do this? And the initial response was, absolutely not. That's not the role for the volunteers, for the actual prisoners. But it went back and forth, and it went back and forth, and they worked with Gary, who's our lead for that prison, who's the guy on the left up in the picture. And they worked out a model to try and test it out and see if they could make it work. So this is my extremely simplified version of their model, in the interest of time. So essentially, you've got this group of really, really strong residents, kind of, hand-picked effectively because they've got really good relationships right across the prison system. And they agreed to use point-of-care tests with oral fluids, so there's no lancets required, there's no blood draws, there's none of that stuff. They were trained, they'd already had quite a lot of hepatitis C training, but they were trained around the tests and confidentiality, data protection, all of the other things that go around that, infection prevention. And then they started to do the testing in reception. One of their other roles was already in reception, so they were kind of known around that system, but they started testing the prisoners as the new arrivals as they came in. What they would do was they would log all of the antibody results, because that's all you get from those point-of-care tests, on a spreadsheet. In the morning, that would be given to the nurse. The nurse would follow up anyone who had antibodies, and that person would get an RNA test that day using a point-of-care RNA device, and if they needed treatment, then they would get treatment straight away. So it was a very, very tight pathway, which is something that we've worked for a long time in lots of our prisons on. And if they need it, they get peer support. And this is what happened. So that little square at the bottom is 2022, before they started doing the resident-led testing. There's a bit of debate about what the actual number was and whether there was some underreporting. So it might have been 25, but it wasn't 30 or 40 or 50% before this started. And in the first month of the residents taking over the testing, it jumped up to 88%. And, that's brilliant in itself, but what I think is really important is they kept doing it, so this has continued. We're now 2 years into this project, and 80+% of people coming into that prison are being tested. So that's higher than lots and lots of the prisons on our estate that use kind of paid workers to do their reception testing. So they tested nearly 4,000 people in 2023, and that was 87% of the people coming into the prison. At least 80 people. It's hard because people move around, so it's hard to know exactly who got treated, and we're still trying to get the details. But at least 80 people were treated and diagnosed in that period, and really good feedback from from the residents, but also from the people doing the testing. So they really enjoyed having this as part of their role. They really valued the help that they were giving people. And, lots of them had their own experience of substance use or hepatitis C, and it's really, it's been really positively received that they were able to help people in that way. They also talked about, so we were talking a lot with the two guys who set this up, and they were talking about how much they noticed that people, as the testing process was opening up opportunities for discussion about people's wider healthcare and their wider healthcare needs, and what medicine hadn't come into the prison with them, and they didn't know how this was going to work. And it also gave those people a chance to ask the expectations team volunteers about what the prison was like. So they were using it as an opportunity to say, what's life like here? How do I get this? What do I do, with whatever? So it was a really, really kind of positive two-way experience for everybody involved in that. So, what did we learn? Can they do it? Yes. From this experience and from some other work that is now starting to build up, it's definitely a viable model, or it's certainly, this is one prison, so you can't make complete decisions or pronouncements on it, but it was really, really impressive the way that they managed to embed this in the way that they worked and how they managed to continue it. The governor has changed, the expectation team people have changed, everything has changed, and that model is still going and they're still doing it. So it seems to really, really have legs. We've now introduced it in 2 more prisons. Those prisons are doing finger prick testing, so the residents who are doing the testing have a lancet, and they're not one lancet, that would be really bad for infection control. But yeah, they have lots of lancets and they test everyone, and they're doing blood draws and all those sorts of things. So it's really, it's starting to scale. We've got another prison that's interested in it. I suppose the big learning, like with loads of these projects, especially peer work, is, relationships are so important to get anything like this off the ground. It is about, there was one advocate in healthcare, there was one advocate, the governor was a big advocate, there was a great group of people. But it does feel like this can be extended, and it can be expanded, and it can be continued. So that's really exciting. We are planning an evaluation, which will hopefully give us a chance to really dive into the data in a bit more detail and get some qualitative work, really understand the acceptability, really understand the ethical considerations, how do people really feel about, privacy and confidentiality and all those sorts of things. So that's the next step for us as an organisation. And I suppose the last thing I wanted to say was, this is a Hep C model. But actually, what it does, what it's about, is pretty universal. It's pretty translatable for any sort of really marginalised population, particularly when you're talking about prison health. So people not getting offered testing, people being fearful of being diagnosed, people with all sorts of different concerns and fear and stigma and all those sorts of things. That sits right across HIV and tuberculosis and loads of different diseases. And there is nothing about this model that couldn't be used in different ways. So I think there are multiple ways that it could be expanded. Thank you.
Do we have any questions? Thank you.
Thanks, Leila. That was fantastic. Just a question in terms of the acceptability from corrective services officers, even though lancets are not a needle, and was there any concerns or risks? And I know in New South Wales and Australia that would absolutely freak them out.
I've just had that conversation actually. So the first pilot, that was absolutely a no-go area, and that's why we use the oral fluid. It's better for people sometimes as well. There are sort of barriers to needing blood. But no, it wasn't something that was considered in Birmingham. It is something that's just coming in now. My colleague Lee at the back is in charge of the new ones, and he could probably tell us much more. And he's doing a talk at about 4 o'clock this afternoon where they're going to debate whether residents can do testing. So hopefully we can get some more information from him.
And really, really quickly, I know somebody else has got a question, but in terms of prevalence, because you've got you've got big numbers but very small prevalence, I guess that's something to think about in terms of cost effectiveness going forward, because that's in a potentially expensive model if your prevalence isn't high. Yeah,
and we're having a lot of conversations obviously we work in all the prisons at the moment, but long term, particularly when you're maintaining Hep C. There's a surveillance element, I think, to reception testing in prisons, and the kind of surveillance of maintaining hepatitis C elimination is going to be really challenging. So there are other considerations as well, but certainly, you know, which prisons are the best? Prisons are very different, and they have very different populations of people, and focusing these sorts of interventions, I think, on where you're most likely to pick it up is also really important.
Thank you so much. We need to move on. Sorry.
Sorry.
Thank you so much, Leila.